Hello, I'm Jason Williams, and today we're going to review central venous catheter placement. We'll talk about when to place and when not to place the catheter, how to choose the right vein to place the catheter in, the steps for inserting the catheter, as well as how to avoid complications during CVC insertion. So common indications you've probably seen before would be substances that require central venous access like vasopressors or emergent dialysis, placing a temporary dialysis catheter. Those dialysis catheters can also be used to remove antibodies during plasmapheresis. But one indication that's growing in popularity following the vascular access guidelines called the MAGIC guidelines, released several years ago, is considering central venous catheter placement in patients with poor peripheral venous access. Specifically, if someone's severely ill in borderline ICU, though on the floor, needs frequent blood draws, especially if they have a low GFR or their catheter is really needed for less than 2 weeks. It's these patients we may want to avoid a PICC line placement, since PICC lines have about a 5% DVT rate compared to only 1% DVTs in central venous catheters. If the patient doesn't need to go home with the central line, consider a CVC instead of a PICC, especially if you want to preserve their arm veins because they have chronic kidney disease for future dialysis access. So when not to place the catheter, you don't want to put your needle or catheter through infected tissue, whether it's cellulitis or infection above the target vessel. You want to make sure there's no blood clots in your vessel. And patients that can't cooperate during the procedure because they're severely agitated should avoid central venous catheter placement as well until they're more controlled. Coagulopathy is considered a relative contraindication because most studies have shown there's no increased risk of major bleeding with moderate coagulopathies, but most of these studies are in experienced providers who've placed greater than 50 central lines. For more novice learners who have a tendency to Swiss cheese the vessel and poke a bunch of holes into various veins, hematomas and bleeding definitely increase with coagulopathy in my clinical experience. So the interventional radiology guidelines do suggest trying to get the platelets above 50,000 and INR less than 2 in elective cases. But in urgent or emergent settings, that's not always possible, and the patient should be consented that they may have an elevated risk of bleeding to the procedure. Also, something to think about prior to placing a central line in the subclavian or jugular vein is whether or not they could tolerate causing an ipsilateral pneumothorax on that side. So if a patient has a unilateral lung transplant, always try to place the central line on their bad lung. So if you pop a hole in the bad one, they're likely to tolerate it very well, versus popping a hole in their one good lung, likely could get them intubated and need emergent procedure to correct that. So how to choose which vein to insert the catheter? The internal jugular vein is the most commonly selected because it's the most ultrasound compatible vein and it's the straightest path to the superior vena cava when coming in from the right internal jugular vein. Femoral vein is a good backup option. There's a very high success rate and very low mechanical complications because it's hard to pop the lung while you're inserting a needle into the leg. It does have the highest risk of DVTs, probably because patients have to remain bedbound with the catheter in place. The bigger the leg, the harder it is to place the catheter. And it should be avoided if the patient has an IVC filter. There's a theoretical risk of getting your wire tangled in the IVC filter. Subclavian vein has some benefits, but also a lot of disadvantages as well. It's the most comfortable, it has the lowest risk of thrombosis and infection, but it has the highest failure rate, it has the highest rate of pneumothorax and arterial puncture, and if you do hit an artery and cause bleeding, it's a non-compressible site under the clavicle, so the bleeding can get quite large. And HD catheter should be avoided in this vein. Since it's smaller, it's going to cause stenosis and thrombosis of that vein. Overall, this 3-sites trial published in the New England Journal of Medicine several years ago showed that looking at subclavian, jugular, and femoral veins, the total rate of major complications is similar. It's about 3% for all of them. It's just a trade-off between more mechanical complications with subclavian or more DVTs and infections with femoral, or a mix of the two with jugular vein. So what we suggest is choose the easiest target and you're likely to be the most successful. So what is an easy target? Well, you want to use your ultrasound to do a good venous exam and ask yourself how big is the vein and how deep is it? So a good target would be large jugular vein compared to the carotid and very superficial, it's very close to the skin. Versus this jugular vein, it's smaller than the carotid and it's much deeper, it'd be harder to hit, and you're more likely to have complications digging around and trying to hit this vein. Once you think you've chosen a good site with ultrasound, be sure to squish the vein and make sure the walls are fully compressible, which will rule out DVT in that vein. Once you've chosen your site, you can get your equipment ready. Look at proceduralist.org in the kit section and supplies. You'll see a list of what our central line kit has and what you need to get and acquire on top of what our kit normally has already. One important thing to emphasize is maximum sterile barrier technique, specifically just bathing the patient in a wide area of chlorhexidine scrubs repeatedly if necessary, and maintaining sterile gloves, sterile gown, sterile full body drape, as well as a mask and cap. And be sure to grab your sterile probe cover and gel as well. So always consent the patient, and if the patient can't consent and family can't be located emergently, you can do a 2-physician consent, noting the benefits outweigh the risks of the emergent procedure. Be sure to make sure the patient's on a cardiac monitor, O2, and blood pressure cuff so you can monitor their vitals during the procedure. Cleanse the area, a wide area with chlorhexidine, and be sure to set up your maximum sterile barrier. Always perform a pre-procedure timeout, both to confirm your patient and the location of the procedure, but you've reviewed the labs and potential coagulopathies, you've reviewed their medications, specifically blood thinners, and you've looked at imaging, specifically looking for DVTs in the target vessel. Then you can prepare your lidocaine and anesthetize the skin. Then you can begin the traditional Seldinger technique. It starts with the introducer needle accessing the vein, and ultrasound has really helped us in perfecting this technique. Several Cochrane meta-analysis have confirmed that ultrasound reduces complications and increases success for not just the jugular and femoral vein, but also subclavian as well. It's really becoming the standard of care. So here, use your ultrasound to put the vein in the middle of your screen and insert the needle at the base of the ultrasound right in the middle. And as you insert the needle, you'll see a white dot appear on the screen, and this is your needle tip. And as you slowly advance the needle and insert the needle deeper into the patient, slide your ultrasound forward and you'll continue to track the needle as it gets deeper and deeper. And you want to follow it as you slowly progress and slowly advance both the needle and the ultrasound, sliding both of them deeper and deeper, aspirating as you advance. And now as you aspirate and advance the needle, you'll begin to aspirate blood as the needle tip enters the vein. And this is ideal. You want to slowly follow that needle tip just like this in your real patients. Once you get in, you'll be aspirating blood here. Then you're going to slowly remove your syringe, keep your needle as still as possible, and make sure you have dark, non-pulsatile blood that's venous, as opposed to arterial pulsatile blood. Venous and not arterial blood. Once you've confirmed venous blood flow, you can then insert your guide wire. You want to insert it no more than 20 centimeters to prevent it going into the heart and causing arrhythmias. Beware of resistance when you're advancing the guide wire. Once your guide wire is in, you can then withdraw your needle. And here's the final time we'll use ultrasound to confirm our wire is in the vein. So you want to be sure to assess both in the short axis view to make sure the wire is in the vein, and continue sliding down to make sure it doesn't go out the back wall into the carotid artery below. And then turn your probe 90 degrees to look at it in the long axis view to further highlight that your wire is in the vein. Once you've confirmed the wire is in the vein and not the artery, you can then make your skin nick, about 2 to 3 millimeters, the diameter of a triple lumen catheter. Then you can begin your dilation. The dilator can be tricky, so you want to hold it with one hand like a pencil, and with your fingertips close to the skin, twisting and pushing right here at the base of the skin. And the other hand is holding the wire, maintaining constant tension to keep that wire nice and straight so the wire doesn't bend or kink during this. And you only need to advance the dilator just into the anterior wall of the vein, and you don't want to keep advancing and potentially lacerate the back wall and push it through and through. Never hub the dilator. After dilation, you can insert your central venous catheter over the wire, and then you can remove your guide wire. Aspirate and flush ports to remove air and then flush the blood out of there with saline. Then you can suture the catheter in place and occlude it with a sterile dressing. Be sure to dispose of all your sharps and get a chest x-ray to confirm the central venous catheter is in the right place and that there's no pneumothorax or hemothorax that's developed. Pain is a common complication, so be sure to use a liberal amount of lidocaine prior to the procedure for the patient. Failure, it happens especially higher when you're first learning the technique versus more experienced practitioners. It also varies by site selection, so subclavian will be the hardest. Arterial puncture is an important one. You really want to confirm you're in a vein and not in an artery, both by looking at the blood flow out of the needle when you remove the syringe, and then also ultrasounding to confirm your wire. All the catheters that we've seen that have ended up in a carotid, the residents have forgot to ultrasound their wire prior to dilation. If you hit the artery with the needle or the wire, just take out the needle and wire and hold pressure for about 10 minutes. If, unfortunately, you've dilated the artery or threaded your catheter into the artery and caused a larger hole in the carotid or femoral artery, then you have to call vascular surgery prior to removal. The vascular surgeons may take the patient to the OR and remove it in that sterile setting in case they have to emergently open up the area, explore it, and potentially sew it back together. Small hematomas are common. Pneumothorax is possible, especially with subclavians. Bloodstream infections and thrombosis, these are time-dependent variables, so the longer the catheter's in, the more likely they are to occur. So always try to remove your catheters sooner rather than later. More serious bleeding can occur, and arrhythmias are important to monitor for on cardiac monitor. And if you do get atrial or ventricular arrhythmias, you can just pull back your wire several centimeters and the arrhythmias terminate spontaneously the vast majority of the time. And during the procedure, especially with high lines, always Trendelenburg the patient so their head is below their heart, so your needle puncture site will less likely to have an air embolism. And the same thing with removing the catheter, that the puncture site should always be below the heart, and the patient should be bearing down and not inhaling in while the catheter is being removed. So just to summarize, always consider central venous catheter, especially in peripheral venous access patients that you're considering a PICC line on the floor if you think it may just be short-term use. Contraindications, always think about, does my patient have a DVT? Check previous imaging and do a thorough vascular exam with the ultrasound to look all the way up and down the neck to make sure there's no clots in the target vein by making those walls 100% compressible during the ultrasound exam. We prefer to select the right internal jugular vein, but if it doesn't look like an easy target, if it's not big and superficial, check the other side and check the femoral veins as well. Always maintain maximum sterile technique to prevent catheter-related bloodstream infections. Really practice on following the needle tip with your ultrasound. That will really increase your accuracy, success, and decrease complications. And always confirm venous puncture and never dilate an artery. Complications can generally be avoided by staying away from the clavicle. So when doing a jugular venous catheter, always stay at least 2 to 3 centimeters above the clavicle. That'll keep you away from the lung. It'll keep you away from subclavian veins or arteries, which you could potentially injure as well. So always stay away from the clavicle if you can. And the quicker you can remove the catheter, the less likely you are to have complications as well. All right, now you can scroll to the bottom of the page. There's a step-by-step checklist you can consider reviewing before all of your central venous catheter insertions, just to mentally prepare yourself for the procedure. And also, there's a nice list of supplies you need in addition to your central venous catheter kit that you can help gather supplies more efficiently prior to your procedure. Thank you, and I'll see you on the wards.